I'm going to present a case that started as an ACS and then kind of becomes a little bit more complicated. A 73-year-old woman with a prior non-STEMI 8 years ago, and at that time she was found to have a tight stenosis of her right coronary artery, underwent successful stenting, and at the time she was noted to have, quote, mild disease in her circumflex and anterior descending vessels. Not an uncommon report to get back from the cath lab. At the time she was treated with atorvastatin 80 milligrams daily, and then she was lost to cardiology follow-up. Again, not a uncommon clinical situation. Now she represents at the age of 73. She has chest pain, which she describes as central crushing and radiating to her left arm. Her other risk factors include that of hypertension. She has type 2 diabetes. She's an ex-smoker, body mass index 29. And at the time she presented, she was compliant with the therapies that she was taking at the time, which included aspirin, atorvastatin at a lower dose, again not uncommon, that patients prescribed high-intensity statin therapy and then returning later at a much lower dose, perindopril and metformin. She has an ECG that demonstrates new anterolateral ischemic changes, and her labs on admission reveal an LDL cholesterol of 3.3 millimoles per litre, triglyceride 2.3, HDL cholesterol a little low at 0.8 millimoles per litre, and HbA1c on metformin of 7.3%. So she goes to the cath lab and she has a 90% lesion of a proximal LAD that is stented. Her right coronary stent looks okay, despite having 8 years of unacceptably high LDL cholesterol levels. She now has what looks like a kind of a moderate lesion in her circumflex. We did a whole bunch of fancy imaging that you see there on the right. She has, we just spend a bit of money on catheters, and she has, that lesion looks like it's got a lot of plaque. It's got some lipid on near-infrared spectroscopy. It's got a necrotic core on virtual histology and a relatively thin fibrous cap. Might be a good patient for my Huygens study that I talked about yesterday. And she has mild left ventricular dysfunction. So the first question is, how many Fourier high-risk myocardial infarction features does this patient have? So I think we all agree she has high-risk features. In fact, she has multiple high-risk features. She has multivessel disease. She now has had 2 myocardial infarctions, but her prior myocardial infarction was 8 years before. So at least from that Fourier high-risk MI subgroup analysis that we saw yesterday, she probably looks like she's got 2, but certainly that puts her in a much higher risk group. And as we saw yesterday, certainly she would stand to derive a much greater benefit in terms of absolute risk reduction than if she had none of those features. Now, question number 2. You've heard the story. What risk factor concerns you the most about this patient? LDL, triglycerides, HDL, HbA1c. And just to remember, LDL cholesterol is 3.3, triglycerides I think were 2.3, HDL 0.8, and A1c 7.3%. So if you're looking at that patient, what's the risk factor that concerns you the most? There we go. Now, sometimes I put up questions of these type where there's no right answer. It's just an interesting exercise to see what people would say. And I must admit, I thought we might have seen a slightly different spread of risk factors. So perhaps an intensive discussion about LDL cholesterol. Larry has certainly, well, Chris did not convince a single person on triglycerides. And well, I wasn't the one who answered the HDL question, Jill. So that's where we go. So I think it's certainly the risk factor that I think we feel the most comfortable with what perhaps should be the next step. So these were the medications that the patient was discharged from hospital on. She went home on aspirin. She had ticagrelor as a second antiplatelet. Continued the perindopril metformin. She was commenced an SGLT2 inhibitor. Her atorvastatin was increased to 80 milligrams daily, and in my hospital she was referred to cardiac rehabilitation. In my hospital she has a 30% chance of getting to cardiac rehabilitation, and she's probably got somewhere in the order of a 30% chance, if she gets to the first visit of cardiac rehabilitation, completing that course. We know there's evidence that those people who complete cardiac rehabilitation are far more likely to be compliant with risk reduction therapies, have better risk factor control at 12 months, and there's certainly some data to suggest that there actually is a reduction in recurrent cardiovascular events. Yet we still struggle in most of our health services to refer these patients and to have them compliant. And in fact, it's older women who are far less likely to attend cardiac rehabilitation than male patients. Now, I think we're still a little uncertain why that has been the case. There has certainly been an argument that male patients are much more likely to have somebody nagging them, to be quite honest, about pushing them to go to cardiac rehabilitation. And often females are really driving the family home, and they certainly need somebody to be nagging them to get to cardiac rehabilitation. So what we've done is we've gone from 20 to 80 of atorvastatin. How much additional LDL cholesterol lowering would you expect that patient to derive from doing that? 0 to 5, 6 to 10, 10 to 20%, or more than 20% lowering of LDL cholesterol? Well, I wish that it was a 20+% increase, lowering of LDL cholesterol. That would be fantastic. So I think we've had this concept for years of the so-called rule of sixes. For every doubling of a statin dose, you get about 6% more lowering of LDL cholesterol. So, I would hope to see that a patient that went from 20 to 80, so two doublings of doses of their statin, most of those patients are probably going to see a 10 to 20% additional lowering of LDL cholesterol in addition to where the patient started. So we saw this patient at 3 months. She was pain-free. She was attending cardiac rehabilitation, and she was compliant with her medications. Blood pressure control wasn't too bad, probably a little bit higher than the US guidelines, but I think most other countries' guidelines, I think probably would be fairly happy with that blood pressure in general. Her LDL cholesterol's come down to 2.6 millimoles per litre. Triglycerides about the same, and her CRP is 2.8. So we don't routinely measure CRP. We know that in the setting of an ACS, in many patients that's going to be 8, 10 plus, and it's going to plummet. And it's going to plummet in that post-ACS setting for two reasons. One, as a just natural function following the acute coronary syndrome. And two, we're going to have this patient on a high-intensity statin agent, which we know will certainly have some CRP lowering that goes along with that. So on the basis of that, what would you do next? No change to therapy, add ezetimibe. You saw the press release on Monday and you got very excited. 4 grams of EPA daily, or would you add a PCSK9 inhibitor? I think, as we saw in the last case, I think appropriate addition of ezetimibe is a very reasonable thing to do. It certainly is in accordance with our guidelines. It's certainly in accordance as well with what is the likelihood in most of our countries in terms of where the requirement is before we can add a PCSK9 inhibitor. There's no doubt that adding a PCSK9 inhibitor at this stage is certainly going to lower LDL cholesterol to a much lower level. But there is also a practical reality of trying to get patients onto maximal therapy, and at least in most of our practices, I think that would be where we would probably have to go in accordance with both a combination of our guidelines and what our payers think. Now, it'll be interesting to ask this same question, Chris, after the AHA when we see some data from Reduce It, because in a lot of ways, this is exactly the Reduce It patient. And we're going to see a 25% reduction in events. And so, as we talked about yesterday, the devil will definitely be in the detail. But it does open up a very different strategy. And we talked about those blue people pathways of Paul Ridker's, and will we get to a situation where mildly elevated LDL cholesterol opens one door, triglyceride elevation opens another? For example, only time will tell from that perspective. So 9 months later, this woman presents with sudden onset left-sided weakness. She has a head scanned, she undergoes successful thrombus removal, she has a good neurological recovery, she continues to comply with medications. Her ECG throughout has shown sinus rhythm with no new ischemic changes. She had an echocardiogram performed during the course of a stroke. She now has normal left ventricular function. We found no evidence of intracardiac thrombus. She did have ultrasound imaging of both of her carotid arteries and had a 40% stenosis on the right side. And here are her risk factors at this point in time. Blood pressure 132/77. Her LDL is now 2. Triglycerides still up just a little bit at 2.1. So would maybe that potentially convince you, Chris, that she's still a reduce-it type patient? And her CRP is still just a little over that 2 mg per litre level that we've seen in a number of analyses that suggest, again, in its own right, higher risk. So question number 5, what would you do next? No change to therapy? Add 4 grams EPA? Add a PCSK9 inhibitor? Or 4, I'd like to add a PCSK9 inhibitor, but I'm concerned about very low LDL cholesterol levels following strokes. And that's exactly what the Fourier trial would tell us that we should do. Now, as Larry said, we didn't talk a lot about stroke yesterday in the context of Fourier. Fourier not only included stroke as part of its composite primary endpoint, we saw a reduction in that parameter in all the patients, but we also saw a large number of patients, somewhere in the order of about 4,800, who entered the Fourier study with their qualifying ASCVD event being a prior stroke. And in the analyses that we've seen to date, we've seen that we see a reduction in the primary endpoint, including essentially coronary events, in that group. Now, we haven't seen the PAD or male data separated out exclusively into those patients with standalone cerebrovascular disease, but certainly the compelling data that we already just saw, where we see male benefit in patients with not clinically manifest PAD coming in. So patients who either had a coronary event or a cerebrovascular event as their clinical kind of gateway into Fourier had a benefit in terms of male. So it really does talk to the systemic nature of the disease. I put 4 up there because I think that's a considerable challenge, and it's a considerable challenge in different parts of the world. My Asian neighbours are significantly concerned about this. In Asia, stroke worries physicians far more than myocardial infarction. It certainly worries patients far more than myocardial infarction. In a lot of ways, we fix our patients with myocardial infarction. Patients worry about long-term paralysis and other neurological kind of sequelae. It's highly prevalent. The demographic distribution is different in terms of the balance between cerebral and coronary events in Asia. And I know that my colleagues on the neurology side in Asia continue to be concerned with this concept of what a very low LDL cholesterol looks like. And we have a history here. It wasn't that long ago in the statin literature where we had concerns that low levels of LDL cholesterol or high-intensity statin therapy may be associated with signals of hemorrhagic stroke. And we've failed to be able to really support that there's a large body of evidence that really confirms that. So we have been reassured as cardiologists about safety here, but our colleagues still have some question marks that we have to deal with. And so this is a nice example of a polyvascular patient where different specialists are likely to be involved in the clinical management of this patient at different points along the way. And we're going to be dealing with colleagues who may be a lot more worried about having an LDL of 0.5 than we would be, despite all the conversations that we've been having, but for very different reasons. And so, it does present a challenge that we face in terms of kind of multiple different clinical departments managing high-risk patients like this. Is there an indication for a PCSK9 inhibitor in this patient? Absolutely. In fact, the patient has a number of entry points into a PCSK9 inhibitor. They have coronary disease. She has a number of myocardial infarction features, which are high risk. She's had prior myocardial infarctions. She's had multiple infarcts. She has multivessel disease. She would stand to benefit even more than just your stock standard Fourier patient in terms of benefit. She has an LDL cholesterol level that is suboptimally controlled on maximum statin therapy and ezetimibe. She has an elevated C-reactive protein. That in itself is an additional risk factor for events. And we've seen another subgroup analysis show us that individuals with higher baseline CRPs and Fourier, again, derived a greater absolute risk reduction from use of those agents. And then what I haven't included on this slide, but I think is an important addition, is that she has an elevated triglyceride level. And in the absence of seeing reduce-it data, in the absence of having specific triglyceride-lowering therapies that are in the clinic, our guidelines actually tell us that the first thing to do with a high-risk patient with a high triglyceride is to lower their LDL even more, is to be more aggressive. So from a myocardial perspective, this patient has lots of reasons to be on a PCSK9 inhibitor and now has an ischemic stroke, and that would also qualify. So we commenced evolocumab. Patient does have an LDL cholesterol of 0.5 millimoles per litre. Triglycerides still about 2. Patients had no further events and appears to be tolerating therapy without any side effects. And on that note, I'll thank you for your attention.